Vamos a continuar con nuestro programa el día de hoy. Ahora me permito dar paso a la siguiente ponencia a cargo de la doctora Erin Olson. Les platico rápidamente. La doctora Erin Olson es psicóloga, licenciada en el estado de Washington y profesora en el Departamento de Psicología Escolar de la Universidad de Washington, donde imparte cursos sobre evaluación y diagnóstico. Su trayectoria comenzó como educadora en la primera infancia, experiencia que cimentó su compromiso con la intervención temprana, la parentalidad positiva y la formación de profesionales capacitados. Obtuvo su doctorado en psicología escolar en la Universidad de Washington y realizó prácticas clínicas en el UW Center for Human Development and Disability, UW Parenting Clinic, UW Autism Center y el Seattle Children's Hospital. Ha trabajado ampliamente con niños que presentan conductas desafiantes, diferencias de aprendizaje y trastornos del neurodesarrollo, incluyendo el espectro autista, lo que ha enriquecido su práctica en evaluación, terapia y consultoría. Además de mantener una práctica privada, es cofundadora del Boyden Autism Center en el Providence Regional Medical Center Everett, consultora en escuelas locales y formadora de padres y educadores. Forma parte del equipo interdisciplinario de diagnóstico de la red UW Fetal Alcohol Syndrome Diagnostic and Prevention Network, desde donde aporta una perspectiva centrada en las fortalezas de cada niño y su familia, promoviendo siempre la compasión y la competencia profesional en sus estudiantes. Doctora, muchas gracias, bienvenida. Adelante.
Right. Gracias por la invitación. Gracias, FISAC. Me siente honrado por esta oportunidad. Mi español es no muy fuerte, así hablaría en inglés y lo siento mis slides, ¿cómo se dice slides? Me olvido. Oh, gracias. Son en inglés también. All right. That's going to be the extent of probably my Spanish today. But thank you so much for having me. I don't have any financial disclosures or conflicts of interest to disclose, but I do want to disclose that the fields of FASD have been ingrained in conflict, bias, stigma, and inequity, which you heard quite a lot about yesterday. So there's a lot of work to be done in this field. It's rife with difficult discussions that we must have and a lack of consensus, even in regarding diagnosis, which I'm going to talk more about today. I do also want to thank Dr. Heather Carmichael Olson and Dr. Susan Ashley Hemingway for their support, and some of the slides here have been prepared by them. Before I get there, I do actually, it's not going backwards. Oh, there we go. I do want to mention that I am I wear two separate hats in diagnosis. In one clinic, in the interdisciplinary clinic at the University of Washington, it's a medical diagnosis, and we use the 4-digit code. I also do a single discipline diagnostic clinic at Seattle Children's, where we use the DSM-5 NDPAE. There's a little bit of conflict there, and it takes some navigating. So those of you who are interested in talking about that more, I'm happy to answer questions. I'm not going to dive into it in depth in this presentation, but I have a lot of considerations and opinions about it. Our objectives today are to understand the impact of prenatal alcohol exposure. We've talked about that a lot, so I'll just overview. Identifying the diagnostic features of FASD and assessment approaches, and considering the value of describing a profile of strengths and vulnerabilities in helping families understand neurodiversity. We also want to learn strategies to address stigma. The title of this discussion is The Washington Perspective, and why is that important? I am biased because I'm from there, but Dr. Sylvia yesterday presented a timeline very similar to this. We do know that alcohol is a teratogen, and it was identified in publication in 1899 in a British journal. Subsequently, it was identified by Dr. Christy Euland, who was a pediatric resident at the University of Washington in Seattle in 1968. And at the exact same time, a pediatrician in France, Dr. Paul Lemoine, was also identifying and publishing on the same phenomenon that she was noticing. She took the observations to two dysmorphologists, colleagues of hers at the University of Washington, Dr. Smith and Dr. Jones, and they then published a paper in Lancet that first coined the term fetal alcohol syndrome in 1973. And then the four-digit code, as you just heard a lot about from Dr. Hemingway, was produced in 1997, and it is now in its fourth edition. And as you are all aware, you're all welcome to come and learn and observe us for free. And you don't even have to leave. You could join us remotely. But Washington State, since the observations of Dr. Euland, has been a leader in research. Dr. Hemingway mentioned the PCAP, the Parent-Child Assistance Program. Dr. Heather Carmichael Olson also created an evidence-based parenting program for caregivers of individuals with FASDs. And we've also trained, we started up a bunch of clinics throughout the state of Washington, and we've also trained, as Dr. Hemingway pointed out, thousands of teams throughout the world who also use the four-digit code. So we're thrilled that you're interested in learning more about that from us, and are happy to continue the collaboration. We all know, also based on our presentations from yesterday and this morning, that prenatal alcohol exposure impacts growth, specific facial features, and both structural and functional neurological differences. When we think about structural differences, we often use head size as a proxy. Oftentimes, we don't have neurological imaging to look at structural differences. So where I come in is we want to think about those functional differences to see if there's an impact. We use that impact as a proxy for structural difference. So the impact of prenatal alcohol exposure on the brain differs by dose, pattern, and timing, and it's very individually variable. And that's something that's very difficult, maybe impossible to measure. So we really want to think about the individual profiles of these youth and individuals with prenatal alcohol exposure. And I do want to point out that without the facial features, which Dr. Hemingway pointed out are 99.8% specific to alcohol, we can't scientifically confirm causality, right? And so we also want to think about what are those other factors that are impacting brain development. And as she had said previously, it's never just the alcohol. We have layers of things that are happening to individuals. We want to consider all of those pieces, the early adversity that they may have experienced, including genetics. We want to think about housing instability, food insecurity, and those types of things that can also cause neurological differences, brain-based differences in our population. So it's a lot to kind of think about in terms of assessment. I'm not going to go through these slides, but there's many areas that are impacted. And when we want to think about a measurement and assessment, I had originally decided, oh, I'm going to talk about all of the types of assessments that are developed in Mexico for Mexican population in Spanish. And I had looked at this actually quite a while ago. My husband has a lab at Seattle Research Institute, the Collab Lab, and we partnered together when he was researching Zika. And back in that time, we were really focusing on Brazil, and we were making a call for folks to follow these children who were born with microcephaly, but to follow them, and even if they weren't born with microcephaly and were Zika exposed, we wanted to follow those individuals to see their developmental trajectory. And so we wrote a paper and published it in one of the Nature derivatives. And I went through and tried to find all of the measurements and assessments that could be used in Brazil. And many of those are English assessments that were developed in English, either at the UK or the US, and then translated. And that wasn't necessarily satisfactory. And it was hard to find tests that were actually published in Brazil for the Brazilian population. Now it's different. I did identify a bunch of tests that were developed in Mexico normed with Mexican population, but I didn't want to have to go in through all of that because those of you that are going to be doing these assessments kind of know the approaches. So I wanted to give a broad overview of what we want to think about when we're assessing individuals with prenatal alcohol exposure. We certainly want to use a multi-method and multi-informant approach so that we can get to all of those areas that can potentially be impacted by prenatal alcohol exposure. Our sources can be direct assessment, questionnaires, observation, and observation on all the multiple domains of development. In our clinic, in our interdisciplinary clinic, the occupational therapist focuses on motor and sensory processing. Our speech language pathologist focuses on communication, all types of communication, including social, verbal, nonverbal, expressive and receptive language. And then psychology looks at cognition. Executive function is a big area for us. Adaptive behavior, memory, also a large area that impact social, emotional, and behavioral impacts as well. When we think about selecting the measures that we use, we heard from speakers, a few speakers yesterday talking about screening measures for alcohol use in birthing parents or pregnant people. We have lots of screening measures for development as well. We just want to make sure that those are sensitive and specific to our population. Screening is a good first step, but then we want to really understand how the child is functioning. What are their strengths and vulnerabilities? And to do that, we want to use some standardized measures. We want to use measures that are given in the child's primary language, which is great, but oftentimes we have measures that were developed on other populations with different kinds of expectations and may not actually apply to the population. It's harder to interpret. Sometimes we have to do that, but sometimes we don't. So you really want to find measures that were developed with cultural sensitivity, that are locally normed. You can take measures that are translated from other languages. You can modify and adapt them and then locally norm them, but you can also create your own measures and do the psychometric work to determine validity and reliability, which is the most important. We want to make sure we're measuring what we want to measure and doing it so that it's stable and valid and reliable. We also are looking at, especially from the psychological or mental health perspective, we're looking at co-occurring conditions. ADHD is one of the #1 co-occurring conditions with prenatal alcohol exposure. Although some of the research is showing that the pattern of ADHD, the impacts of ADHD are somewhat different than those without prenatal exposure. So those might be some articles of interest for you to look into. We see learning disabilities, oftentimes in math, not always, but then reading and writing as well. Conduct diagnoses are very frequent due to behavioral and emotional regulation challenges. Oppositional defiant disorder or conduct disorder may be a diagnosis that you see. Also, because of the dysregulation, we see disruptive mood dysregulation disorder quite frequently. And then later in life, we may see other co-occurring conditions such as anxiety and depression that just come from living life with adversities and potentially not a lot of support and an environment that wasn't necessarily designed to support you. This is an example of a developmental domain wheel. This is actually a profile of strengths and vulnerabilities, and it's one that's typically found in children with prenatal exposures. And what I wanted to illustrate here, I know there's no labels for the dots, but I'll just give you an overview, is it demonstrates the complexity of this population. There are significant strengths. So even within one of the areas, for example, cognition, they can have a strength, say, in verbal reasoning, but a deficit in nonverbal reasoning. So there can be discrepancies even within a domain. Excuse me. As you can see, we see deficits in executive function. Memory, we might have very strong long-term memory, but short-term memory might be the area of impact for that particular individual, which can be a double-edged sword if they have exposures, like very adverse early exposures that they hold on to, right? Same with communication. We might have great language skills, which might mask some of our challenges, but our social communication or our organization and planning, which goes along with executive function in communication, might be impacted. Motor, we can see gross motor, as long as they're moving, gross motor tends to be a strength. Stop them and make them balance or balance on one foot, that's another story. Fine motor challenges are often frequently seen as well. So you can see this pattern of strengths and weaknesses here, and everyone is individual. And this is the type of thing we want to be able to explain to caregivers, because what this does, and educators, what this does is it tells us that there are brain-based differences, and we can make sense of why maybe the academics, they have the capability of learning this, but they aren't actually showing what they're learning because of their executive function or memory challenges. And so then we can identify and target our interventions and accommodations more thoroughly. I do want to highlight those strengths. Those are so important for our population. This word cloud was developed by Dr. Christy Petrenko at the University of Rochester. She gathered just positive attributes that caregivers gave to their children, and just found many positive attributes: artistic, caring, loving, helping, humorous, motivated to please, socially motivated, so many positive things that I just wanted to point out here, that we often talk about the deficits and we often focus on the deficits, but we also have to build the strengths. And those are areas where we can put a lot of effort into. And we need to remember that this population is there and needs support. And we want to think from that perspective, how do we set them up for success? When we share the diagnosis with families, we want to obviously clarify the diagnosis. As Dr. Hemingway pointed out, caregivers do understand these diagnoses. We also do not want to neglect the other impacts, right? We do need to talk about early adversity. We need to talk about genetics and environment, experiences, opportunities, all of those things that could contribute to brain-based differences, so that families can understand their children and support them. We focus on the strengths and we positive forecast. We heard yesterday, and we will see again today, I think, if I kept those slides in, that there are some potential very challenging outcomes if we do not provide supports and provide supports early. So we want to make sure that we prevent that from happening by changing how we're working with these individuals. A lot of times, my early training is as a school psychologist, and a lot of these children were labeled as naughty. They were the bad kids, right? And we need to help caregivers and educators reframe that they need special help, so that they don't have to act out to communicate their needs, that they can get the support that they need and then be successful. So interventions work, as Dr. Hemingway said, and accommodations are very important, especially if you're looking at prenatal alcohol exposure as being brain damage in utero, right? We want to level the playing field. A lot of times, people with prenatal alcohol exposure are working a lot harder to do the same thing as someone who's neurotypical. So we need to level that playing field for them. We also want to capitalize on strengths and interests, and I just can't say that enough. Caregiver considerations are important when giving the diagnosis too. We always make sure we have a box of tissues on the table, because we're dealing with emotions. These are big emotions. These are their kids that we're talking about, and they're hearing that their children may have challenges even into the future. Biological families may be wrestling with emotions of self-blame and shame. They might be very worried about the future. I would say adoptive families, foster families would be the same. They may also be angry, feeling anger at the biological families or caregivers. So there's a lot of emotion that's happening in there. So we want to make sure that we're focusing on the courage that it takes a biological caregiver to come into clinic and bring their child in and to talk about their substance use, or the fact that they used when they didn't know that they were pregnant and are worried that it caused some differences in their child. So we want to make sure we're acknowledging their effort, the challenge of raising a child with neurodevelopmental differences, and the dedication that they have towards their children. So we want to make sure that we're kind of capturing that whole package of the onion, the complexity of these children, hence the onion there. Post-diagnosis, so what do? We, in all of the clinics, we generate recommendations. And as you noted, the interdisciplinary diagnostic team does not have the capability of providing intervention, but we still find that just getting the diagnosis is satisfying to caregivers. It helps them reframe their child's behaviors. It helps give them a pathway and what to do to help support their children. At Children's, we have limited follow-up care that we can give at Seattle Children's Hospital. So we do provide some intervention, but a big goal for these families is to get them connected with community, to make sure that they have resources, because oftentimes they feel isolated. And so we want to make sure that they have the support that they need. We want to remember that caregivers need that support as well. They need a break. They need respite so that they can rejuvenate and become and do the effortful work it is to caregive children with neurodiversity, to parent children with neurodiversity. I always try to think about the audience as well as who we're talking to, avoiding jargon language, giving overwhelming lists or lofty recommendations that they have no opportunity to access. So we really try to think individually and what resources are available to them. Outcomes. So here I did bring these slides in. Why do we care? And then what do we do about that? I did do one slide in Spanish. So this is a quick poll for you. So basically, what do you think out of these areas is the most prevalent? Oh, my there was a UU there, I swear. It was EEU. Oh, it's down below. I see it. But anyways, in the United States, in our data, what do you think is the most prevalent life impact or impact on life that people with FASDs encounter? And out of these, they all are potential impacts. We talked about that yesterday. Anybody have one they want to shout out that they think? Oh, I can't. I will just, everybody talked at the same time and most of it was in Spanish. So here we go. Was that what you said, mental health? Okay, and that was right. Mental health problems are the most prevalent challenges that we see in all ages. And so certainly from a psychological mental health perspective, that is an area we want to make sure that we are providing support. These outcomes are from those that did not have appropriate interventions. So I'm not going to say that everybody with prenatal alcohol exposure is going to have these outcomes, but if we can provide supports, we can prevent these outcomes. So you can flip this slide in your mind and think of these are areas where we need to think about prevention and support, right? Dependent for those over 21, issues of trying to live independently. So we need to have supports for providing independent living. We also need to provide supports for employment, supports on the job. These other areas are prevalent, so we want to think about those as well. Many of those have to do with challenges with executive functioning, challenges with inhibition, challenges with memory. So we want to consider those areas as well. This is from Dr. Ann Streisguth and Dr. Heather Carmichael Olson, thinking about what it is and why is it that these individuals need some intervention. And it's not just about this, it's this cascading effect, essentially. Prenatal alcohol exposure potentially can cause brain-based differences, not always. We do have resilient fetuses, as you heard from our twin study, but it can cause brain-based differences. Those brain-based differences, if there are no interventions in place, can cause behavioral problems and other challenges. It's that lack of the brain environment fit. Then adverse outcomes occur. Again, if we flip this in our minds, we can develop a model for approaching supporting individuals and thinking about if we know about the prenatal alcohol exposure, we can identify the individual profile of brain-based differences, we can prevent the behavioral problems, we can prevent the adverse outcomes, and we can set them up for success. All right, so clinical management. This is something that we all need to consider. None of us are immune from our own personal biases. So we want to be aware of our own biases. We want to be aware of those systemic biases. So self-reflect and consider, what might be an impact to having these difficult conversations with families. And then how do we overcome that? What kind of language do we use to support families and kind of get over our own biases? And we want to use effective FASD-informed care. So what do? We talk about it. We use the words. We talk about brain-based differences. We talk about the potential that prenatal alcohol exposure can cause brain-based differences. We talk about differences in neurodiversity and how do we support individuals. An important aspect is that we ask every birthing or every pregnant person about alcohol use or substance use. Everyone, regardless of socioeconomic status, regardless of skin color, regardless of cultural or ethnic aspects, everyone gets those questions. And what we heard yesterday from one of our speakers is that not only do we need to ask it during pregnancy, we really should be asking it during any annual or well visit, right? And giving them the psychoeducation in advance so they understand how to prepare, how to start planning a pregnancy, because that's also some of the best ways to prevent prenatal alcohol exposure. We also need to talk about men's use. We know that now from some of the presentations earlier as well from an epigenetic standpoint. So it's not just women's alcohol use, it's men's alcohol use as well that can be causing or at least predisposing these fetuses to adverse impacts. Let's see. So this is basically that cascading effect written in a positive, what do we do about it way. So we screen, we do the screening, we screen everyone. We evaluate the risks, FASD, oh my goodness, sorry. Evaluate FASD signs and risks. We decide on a diagnostic option. If you are doing a single discipline diagnosis, you probably would be considering a DSM-5, the NDPAE rule in or rule out. If you are doing an interdisciplinary diagnostic approach, then you using the 4-digit code is a very appropriate and very specific. NDPAE as a single discipline provider, we have to do more of a transdiagnostic perspective. So as a psychologist on the clinic where we do the single discipline, I'm often doing some of those assessments that our occupational therapist would have done in the interdisciplinary team, or that our speech language pathologist would have done on the interdisciplinary team. And I would say that while that's efficient and pretty effective to have one person doing those things, it's not as robust because I don't have the expertise or the lens or the language ear of a speech language pathologist. I don't notice the movement or maybe the tremors or things that an occupational therapist might notice. So having that interdisciplinary team can also be a very rich approach. And then of course, managing. What are we going to do? How are we going to support folks? So management recommendations that I have here that I know Jen Wisdahl is going to talk a little bit more about, especially from a family perspective. Certainly from an individual perspective, we want to evaluate and treat mental health, right? That was our top impact. We do have higher rates of comorbid conditions. We do have suicidal ideation and actual suicide victimization is very prevalent in this population, especially from a perspective of being very socially motivated and wanting to please, having difficulty thinking consequentially at sometimes, and that desire to please and be included can very much overweigh consequential thinking too. So, so we want to make sure that we give them support and self-advocacy. We also do know that they're at higher risk for developing their own, if their family or if their caregiver was had a substance use disorder, and then were also prenatally exposed, they have risk for developing their own substance use. So we want to monitor for that as well. And also, when we don't have societal supports in general, that's sometimes what we do. We self-medicate with substances. And so we also want to make sure that we put those supports in place to prevent further substance use. Advocate for neuropsychological and learning disability testing. Again, reframe. We can reframe those behaviors. We can develop accommodations. We can identify some of those hidden disabilities that we may not have noticed before because behavior was masking it. And then monitor comorbid health problems that we often will see. Anything that can come with the midline exposure, right? The heart challenges, the medical pieces certainly need to be monitored. And also for families, what we have found in our studies in families moving forward is that our caregivers need more than typical parenting programs. Parenting programs are great. Evidence-based parenting programs. I love providing programs for families. What they need is a parenting program with a neurodiverse lens that also connects families with resources, with community, networking, so that everyone is integrated. And again, that respite and that support and helping caregivers even think about their own self-care. So family support, FASD specific support like Families Moving Forward, caregiver substance misuse treatment if needed, not always. FASD prevention if desired. PCAP is great for that program, that parent-child assistance program. And then case management and just helping with person-centered planning through the future. The patient you may want to refer for, again, person-centered planning, mentoring, life skills training, concrete help, their own counseling to develop self-regulation skills, attention, some memory skills, social skills, executive function, coping strategies. What I have found in this population and serving an intervention is that these interventions work. We often have to get creative with them. It often requires repetition and many years. I worked with a young child from ages 2.5 to 13. And by 13, he was taking deep breaths. He was using his, strategies to calm down, mindfulness strategy. He was able to do that. And yet still he had a quick trigger, right? And so we had to give him space. So his caregivers also had to learn strategies to help him manage. It wasn't just him on his own. We talk a lot about the myth of independence, that we're never just alone, right? We never do anything by ourselves. We rely on our family, our friends. We all have a network. We're not necessarily isolated. That isolation causes more mental health problems. So we want to have people be have interdependence be more accepted, that it is okay to rely on family and friends. One of our the faces that you see that Dr. Hemingway put up and that you've probably seen in the media, we've been contacted by that individual in her adulthood, and she has described, and she has full FAS, and she has she has a job. She has a very unique, creative job, and she's very successful in her job. But she does talk about how she has difficulty budgeting, managing her checkbook, organizing and planning herself. And so she found a partner, her life partner, who has those strategies and those skills. So I think that we all kind of do that. We tend to find a person, if we're going to spend our lives with someone else, we find someone that kind of helps, with our own challenges and kind of helps us even out. So so that's another way that independence is not a true thing. So we support each other. And so it just shows that society can continue to support folks with prenatal alcohol exposure too, by giving them the care and the even equal opportunities that others may get. I think that is it on those. We have lots more to talk about with Jen Wisdahl, but I do have just a few resources. These are just from the US. That cdc.gov still has FASD stuff on their website. That we weren't told to take that down. FASDunited.org, you're going to hear more about that. The Families Moving Forward program, I'm going to be a proponent of that, so please check that out. And then the UW FASDPN, which you heard a lot about. I put the website up here again and encourage you to come and join us and see what we do up there. And also the TIP, the Treatment Improvement Protocol. It's a little old on the old side, but it still has very relevant and very great ideas. It's addressing fetal alcohol spectrum disorders. It was developed through a work group from SAMHSA. It's available for free online. And if you were able to, you could click on it, but you don't have the slides, so I apologize for not putting the link, but you can Google it. And then I have some resources. Are you all sharing the slides with attendees? I am okay with that. So you'll have those links. Thank you very much for having me. I very much appreciate your time and attention. What do I need?
Tenemos tiempo para preguntas. No sé si alguien quiere hacer alguna pregunta. Ah, de ese lado.
I'd like to thank Erin and Susan, who had to leave early, for coming all this way, not only for their presentations, but also for their amazing work at the University of Washington. I'm a parent, a caregiver of a fetal alcohol exposed child who's now 25. I adopted her when she was 2 years old, and we got into the program, and she was assessed and evaluated by the multidisciplinary team at the University of Washington when she was 16. And I can tell you, it has made all the difference in the world. And I only wish that we had done it sooner. It would have made even more difference in her life and in mine. And I'm...
Thank you, Karen.
Hi, good morning. My question is about outcomes. And according with outcomes, mental health is one of the most common problems. But can you tell us, please, some example of this? And what is recommendation to work with people who experience fetal spectrum disorder?
So specifically, what mental health conditions do we tend to see as an outcome? Is that?
Yeah, related with psychology. It's
Yeah.
more from psychology.
Yeah. Yeah. And I think we tend to see more mood and anxiety-based challenges in this population that are related to their lifelong experiences of adversity, of the barriers and the bias that they encounter, the untreated learning disabilities that may make school difficult. So it becomes a cascading effect, right? And so we would use typical interventions that we would for those conditions, cognitive behavioral therapy, dialectical behavioral therapy, all of those types of therapy work, but we do need to get a bit creative with it, especially depending on the age. Oftentimes we need to have more hands-on, more role play, more experiential learning, practice of strategies of coping skills, actual maybe in the moment or in the situation experience and practice as well, so they can generalize better. So we just tend to have to get a little bit more creative so it's engaging as well. I do find it's very hard to do intervention with youth with FASDs and or ADHD through telehealth. So oftentimes I would recommend in-person interventions.
Okay, thanks.
Hola, muy buenos días. Agradezco bastante toda la información que nos ha expuesto el día de hoy. Comparto la misma visión que la compañera. Yo trabajo en una casa hogar, tengo 4 años trabajando en una casa hogar y en el 2023 llegó un niño con espectro alcohólico fetal. Yo estoy certificada como familia de acogida y claro que el estar aquí me llena mucho de posibilidades para poderles brindar esa atención que los bebés necesitan. Este bebé fue un bebé abandonado que quedó en el hospital pues, por su madre porque consumió drogas y alcohol durante todo el embarazo y llegó a nuestra casa hogar. Esta casa está ubicada en Chapala, Jalisco, y no sé si conozcan que en esa comunidad hay bastantes casas hogares. Entonces, toda esta información que usted me ha brindado, le voy a dejar mi tarjeta porque necesito capacitar y capacitar al personal que va a estar trabajando en esta asociación que voy a crear sin fines de lucro, que se llamará Cunas de Esperanza Tomás, porque queremos darle una cuna a estos bebés que Dios nos va a mandar y porque Él les dio una segunda oportunidad. Entonces comparto bastante este sentir de querer ver bien a estos niños y de quererles dar una oportunidad. He venido aquí a capacitarme y estoy encantada con toda la información que me han brindado. Y claro, estoy tomando fotos de los enlaces porque siento que una persona capacitada puede ayudar mejor. Muchas gracias.
Thank you. I appreciate it. I'm happy to collaborate.
¿Alguna otra pregunta?
Quisiera agregar que mi hija también ha experimentado todos los resultados adversos que mencionó Erin. A pesar de eso, el conocimiento que yo tengo ha cambiado todo. Y eso es, bueno, no es lo más importante, pero sí nos ha cambiado la vida. Gracias.
Tenemos otra pregunta de este lado.
Muchas gracias. Me gustó mucho la presentación. Me gustó mucho la parte en la que menciona la necesidad de conversar y conversar y conversar alrededor de estos temas para reducir, pues, los prejuicios alrededor de, y algo que me pregunto y quiero preguntarle es cómo en, digamos, en una sociedad ahora tan comunicada, donde hay mucha desinformación, donde no se habla tanto de estos temas, donde sí hay muchos prejuicios, ¿cuáles son los foros que ustedes utilizan para subirlo, elevarlo y conversar científicamente y poner en el centro el problema y no la política?
Yeah, thank you. Um, we we in the United States are having a lot of misinformation right now too. Um, what we have done is our team goes around and we do actual trainings to schools, to medical providers, and provide and I am the training director at our autism center, which is where our prenatal exposed clinic also is. And so we train the next generation. And one of the things that we always do is we make sure they're asking the question of prenatal exposure or substance use during pregnancy of everybody. And we make them practice so that it gets, so they can normalize it. If we talk about it normally, it's not stigmatizing. When we hesitate and, tiptoe around it, it makes people feel uncomfortable and that it's not okay to talk about, right? And so we want to make sure we're training everyone in the area. One of the things that FISAC has done is in your bags, I believe you all have an interpreted version of stigmatizing language and ways to use more appropriate language. So we have FASD United that does great work putting out informed, well-informed and appropriate and evidence-based information to at a national level. So creating groups like that will also be helpful and important. That's my timer saying I'm supposed to be done.
Tenemos una
I'll make
última
it stop, but-
pregunta. Tenemos una última pregunta de quienes nos escuchan por Zoom. Mi nombre es Beatriz Gamarra, soy de Paraguay. Mi consulta es, ¿desde qué edad un niño puede iniciar en los vicios? Gracias.
Yeah, so it depends on access, right? I've seen children who have inadvertently gotten into a parent's or a family member's, substances, or, we've heard of very young people, starting to use drugs. I think that this is why we want to make sure that we have prevention education, psychoeducation around substance use, what it can do to our own bodies, and if we are capable of birthing or being pregnant, then what it could also potentially do to our children. So yeah, that question leads me to think of early education is very important throughout the lifespan.
Muchas gracias. Pues si ya no hay preguntas, vamos a entregarle la constancia a la doctora por su participación.
Grab my phone.